All right, well, thank you for that. And it is, how's the sound? Is that too loud? Sounds a little loud. Okay. It's good to be here. I missed Hint last year, and I'm so glad to be back. The conversations that I've had with many of you have been just so illuminating, and I wish I would have had some of them before I did my presentation, because some of them would have made it into the presentation. Unfortunately, you have to have your slides here, pretty early. But anyway, I appreciate the slot. I appreciate Zach giving me a speaking slot. I think what I have here today is going to be helpful. I hope it will be the start of a conversation. I'm going to present a framework, and a framework by definition is just 2x4s and wiring and pipes, right? It's going to need more stuff hung on it, more drywall, whatever. And I think there'll be a lot of ways that we can iterate on this, and there are people in this audience that will probably be able to help build this out a little bit more. So I want to, before I jump into the material, let me just give you 30 seconds on how I got connected with DPC. So back in 2015, I was at a Society of Actuaries meeting and for continuing ed, and there was a session there that a doctor named Josh Umber, many of you know Josh. I don't think Josh frequents these circles, but he was a pioneer, and he gave a really good talk. And when I heard his talk, I was immediately sold on the idea. And I knew that it was small. It was even smaller back then, right? Well, like quite a bit smaller. But I was sold on the idea. It was very small. I knew it was going to grow, and I wanted to skate to where the puck was, right? And now, look at where we are now. It's much, much bigger, still growing. Fast forward 1 year, I went to the DPC Summit, and that was much smaller back then as well. And I went there, and I kind of crashed the party. It was mostly doctors, and I think some of the doctors, you could see them leaning over and going, what the hell is this guy doing here? They didn't know why an actuary would want to be at a DPC conference. But what I was doing was I was learning, and I was looking for data. Because as an actuary, my first thought was, this thing is it. It's gonna work. The only question is to what degree. How much savings can we get from it? How much value is gonna be added? So I immediately went to wanting to quantify this. Fast forward a little bit more, we did get the data, and we published our study in May of 2020. And many of you know that study. It's the Society of Actuaries study. I won't go into it. Most of you have probably read it. So we are working on another study, and that is due right now. We are on track for 1Q of 2025. So we have multiple employers this time. Many of you in the audience have contributed data. Thank you. If you want to contribute your employer data or think you can, we are still accepting data. We will take as much as we can possibly get, and so we are going to repeat that study. And I think it's going to come out very nicely. So that's how I got connected. So let's go ahead and jump in. And just very quickly, you don't have to read this. Let me just tell you what it says. I'm going to have some numbers in the slides. Please don't use them to build your pro forma for your business plan. Okay, these are just illustrations. They're very reasonable, and they're good for the purposes at hand, but just don't use them. Any opinions that I have are mine, they're not my employer's, and according to the American Academy of Actuaries, apparently I'm qualified to say what I'm going to say. So, allegedly, right? So, all right, so the title of my presentation comes from a story, and this is the story. When I was a young parent, I'm an old parent now, but when I was a young parent, I came home, and my wife told me, hey, honey, I signed us up for a parenting class, right? Now, 20 years later, I know what she was really saying. What she was really saying was, I signed you up for a parenting class, right? She was locked in, right? She was ready to parent. Us guys, I don't know, we need a little help. So anyway, we took the class, and one of the things that they taught us in that class was, when you are teaching your child character virtues, you don't just say, well, Johnny, be kind. Why? Because Johnny doesn't know what kind means. You can't say, Susie, be generous, because they don't know what that word means. They don't think abstractly. They need concrete examples of what does kindness look like. And as I thought about that analogy, I thought, I think maybe that's applicable to the DPC space, I think it's applicable when we talk to employers. There's a lot of confusion out there on employers on what exactly DPC is. It seems like a very simple concept, but you'd be surprised at how low the understanding is, honestly, even with benefit brokers. We have an opportunity to explain, almost like a 2-year-old, almost like you're explaining like a 2-year-old, what DPC is, how it works, what happens after you pay the fee, where do the savings come from, how big are the savings, what's the timing of the savings. So all of these things are things that we can probably build a framework around to help communicate this. Now the framework I'm going to present today is maybe a little too actuarial. It's not bad, you know. We could maybe dial it down a little bit, maybe dial up the marketing, you know, but you'll get the idea here. So think of it this way too. When you go to an employer and you want to convince them to buy your product, you're asking them to make an investment, right? Would you agree with that? And you're asking them to pay more up front, because it is more up front, but there's downstream savings, right? So that is the definition of an investment. And when you make an investment in a mutual fund or whatever, you always get this thing called a prospectus. You ever seen these things? You get them in the mail, they're about this thick. They're supposed to give you information on what your investment is like, what the risks are, talk about the return, right? They're about this thick. I usually throw them right in the garbage because they're mostly useless, right? They make you feel like this guy right here, right? They're just not really all that helpful. The idea that I have here is let's build something that's helpful. Let's put together a framework, a communication framework that will actually help them understand what the product is, right? And then we can be like Will Ferrell, and we get it. Every actuarial presentation, by the way, has to have a Will Ferrell meme. I don't know if you knew that or not, but it's a very obscure rule, but it's out there. So anyway, we want them to get it, okay? So we all went to college. We all paid exorbitant amounts of tuition to learn fun little equations like this. So let's get some mileage out of it. I'm going to rearrange it a little bit. And thing one today, I'm going to use this as a structure for the talk. Thing one, we're going to talk about lower costs, how DPC lowers the cost. Thing two is going to be higher quality. And I don't mean quality here is not clinical quality. It's just good old-fashioned standard product quality. It's just you guys just have a better product. Okay, that's what we mean by that. All right. So here's what we don't mean by net cost. Okay, we don't mean sticker price, obviously. Okay. Nobody really buys a car like this, and if you do, let's talk afterwards. I mean, unless you're in the market for a 72 Buick LeSabre, this is not the calculation that you make, right? We all do a more complex no, it's not complex, but it's more than just this, right? What we do is this, right? We think about the sticker price, then we think about all the other downstream externalities that might occur. Repairs, mileage, insurance, right? And we do these calculations in our head, and then we come up with what we think the net cost is going to be. Now, the problem is I think that employers are doing the sticker price. I don't think they're making this calculation. I don't think they can make this calculation. They simply don't know, right? And they certainly don't know all of the components and the magnitudes of each. So it's very difficult for them to even understand some of the mechanics here. So that's really what we want to do for them, is to help them do this and help them to understand some of these downstream externalities. So let's start with lower net costs. I've got 4 buckets. Now remember what we're trying to do here. We're trying to get specific, okay? We're gonna try to break this down, okay? So I've got 4 of them. The first one is what we call diverted claims. Okay, now this is very simple to us in this room. If you've done DPC for any amount of time, this isn't even 101. This is just, all this is all of the claims that were fee for service, now they're under the fee. So when the employer goes to write his check for his downstream claims, these are things like your E&M codes, right? Your venipunctures, sutures, all this kind of stuff that you would have billed. Okay, all of that is now under the fee, so they are not going to appear in the employer's downstream claims. Okay, so that's one source of, quote, savings. In a way, it's just financing, right? Same services, you're just paying for them differently now. But this particular point, again, as simple as it is for us, employers don't understand that. I was talking to David Pinkert just 2 days ago, and he said that he ran into an employer who thought that the $95 fee was just extra, right? It's just on top of what you're already paying, right? That there's no offsets anywhere, nothing, no diverted claims. It's just extra that you're paying on top of that. Now I ask you, if that were the DPC value proposition, would anybody in their right mind pay $95 or $85 or whatever the fee is, okay? Obviously not. And so this is one of the most simplest ones that we're going to talk about, and I suspect that there are employers out there that don't even understand this one, and there are probably benefits consultants that maybe don't either. So simple to us, but maybe not so simple to others. Next one is avoided claims. So this is where the model kicks in. This is where you start actually reducing oopsie, there goes my animations, there we go. This is where you actually start reducing the claims. These are the things that don't happen because you have DPC, right? So reduced emergency room, reduced urgent care, right? Those are functions of the product itself where you have broader access, so you are reducing the usage of those, you're optimizing the site of service, you're bringing them in the office instead of the ER. Specialists go down because you guys refer less, right? You like to keep it in-house, and so you have a broader scope of practice generally, so you generally tend to see less specialist visits. So these are claims that don't happen as a direct result of the model, okay? Now there's more on that list. That's just one, those are the high-profile ones probably. Okay, then we have health improvement, okay? So this is a novel concept in medicine these days, is you're actually healing people, right? You're actually improving the health of the populations that you're serving. You have fewer conditions because they're resolving. The conditions that you do have are managed. You have fewer acute exacerbations, right? You're actually improving people's health. Very quick anecdote. I wasn't going to throw this in, but I'm going to now. When I was a young actuary, the CMO of our insurance company, he told me, he said, yeah, chronic conditions, you don't ever really get rid of them, you just have to manage them. You can't really be healed of them. Now, how many of you believe that? Nobody. I believed that for 15 years, right? That once you get diabetes or something, that it's just, you're toast, it's over. So that was false, but that shows you, I don't know. I don't know why I throw that in. I think it's meaningful to me because I just realize now that we're sold a bill of goods in some cases, but all right. So we put them all together. We've got those three buckets, and I want to just kind of review these real quick, and we'll put them all together and you can see how they relate. So diverted claims, like I said, it's the same number of services basically. And you're just changing the way you pay for them. There's no real change at this point in health status. You're just changing the financing, right? The avoided claims, like I said, now you've started to lower the actual claims. The downstream savings are starting to come in. Haven't done anything on health status yet. Now we get to health improvement. You're improving, the services go down because you're improving the health of the people that you're caring for. So the point in this is that the way we analyze this and the way that we're going to stack these up, these are all mutually exclusive buckets, the way I've calculated these costs, okay? So we're not double counting, we're not overlapping or anything like that. That way we can add them up on a graph, okay? Real quick on timing. I'm going to just put all three of these up, okay? You can see diverted claims, the timing of those is immediate, right? Once you do a total replacement on DPC, you're not going to get any downstream claims, from like I said, from your office-based services are now all going to be under the fee. So that happens immediately if you have a total replacement and no leakage. The avoided claims are generally short-term. So pick a number. I'd say, you might know better than I do. 6 to 18 months, right? You need a little bit of time to let the model get some traction, change people's habits, things like that. And then health improvement is more longer term, isn't it? Now we can quibble about what long-term means here. A year, 2 years, 3 years, again, be open to any of your ideas on there. But I think the general construct here is correct, that each of these has a different horizon of savings. And I'm going to talk a little bit more about that towards the end, but just wanted to introduce that here. The last one was reduced UM spend. So my theory is that if DPC docs are doing what they're doing, managing the care, triaging, managing the medications, the interactions, optimizing the site of service, all the stuff that you guys do to manage a case, my feeling is that some of that is probably already being done by your TPA, and the employer is getting charged for that. So they're potentially spending more money than they need to on the TPA's when you guys are already doing that for them, okay? Now, I don't know how realistic that is, to go and negotiate a lower fee on that. If I were a self-insured employer with DPC, it's what I would be doing. I'd say, I don't want to pay twice for this. So, let's see where we stand. Okay, now I've chosen an arbitrary $85 fee. If your fee is more or less, you can just adjust these numbers. It doesn't change the messaging at all. And let's stack this up and see how we stand. So this is the diverted claims. Remember, these are just the finance claim, just different financing, $40. So we're not quite halfway there yet. Avoided claims, around $25. Okay, and then the medical management piece of it, I went pretty conservative on, but it's probably single-digit dollars, if you even did it. But I threw it in there because I feel like it should be added in. So that gets us to $68, which is about 80% of the way to the fee. All right, and this is just the diverted claims, the avoided claims, and the And you'll notice that there's one bucket missing, isn't there? And that is you got a $17 gap. I did the math for you there. We do not have the health improvement bucket on there. Okay, and that's a pretty substantial piece of it, right? The reason we don't have it on there is we don't really have any data for it yet. Our first study did not, you really need to do a longitudinal study, like a pretty complicated longitudinal study, and look at outcomes over 3 years, 4 years, or something like that, probably 3 years minimum. We don't have that in our first study. We're not doing that in our second study either. I don't even know that the data exists right now with DPC being so young. It could, and if you know of any data like that, we would love to take a look at that. But the health improvement piece is longer term, and it takes a little bit different kind of study than what we've been able to do. But that is a significant piece in there that is not in there. One thing I would say is that, when we communicate to employers, there is a way to kind of fill this gap, this health improvement gap, but it's more of a qualitative way, right? You have to talk with your case studies and your stories and really talk about it qualitatively. What do you do to improve the health over the long term? So there is a way, but it's a qualitative way. Okay, real quick on the quality. So again, we're not talking about NCQA here or anything like that. We're talking about the product quality. So one of the things that happens under DPC is you will actually see, and maybe some of you have seen this, you should see, theory would predict, and I think it's our previous data showed this as well, your primary care utilization actually goes up, right? You're going to see more, come on. You've taken away the financial barriers, zero copay, right? And financial barriers are usually things that are used, deductibles, coinsurance. Okay, these things are put in place because they're partially used to prevent utilization. They're supposed to prevent unnecessary utilization, but sometimes they just prevent utilization altogether. People need care and they don't go get it. But in this case, you have taken the copay away from the primary care, and when you do that, you're going to see more, and you have excellent access, right? Same-day appointments, all that kind of stuff. So you will see your primary care utilization go up. Under fee-for-service, the employer would be paying more to get this increased utilization. It would cost him more, but not under DPC, right? So that's kind of a key thing, is that everybody says, hey, we want more primary care utilization. We need more primary care utilization. That's what drives the savings, right? But then nobody likes to pay it on a fee-for-service basis. Nobody wants to pay it because it just means more cost for them. But see, under DPC, that incentive is removed. So that's a huge product. That's a huge quality feature. Remember cost sharing? This is a real simple one. Most people have a deductible or a copay, even on their primary care. The $0 copay is just better for the member. It's just cheaper. Okay, so there's a direct value to the member, and that really needs to be factored into the value equation here. Can't forget about that. Last one is just a catch-all bucket. You just have a better product. Okay, We're not going to spend any time on this. We all know this, okay? We all know about no wait time and all that. We're not going to go through all that. But you just simply have a better product. Now, I would point to the 2 bullet points at the bottom. Lower absenteeism and employee retention. Now, that's an example of some of these that we've all talked about. I think I've had many conversations with people that talk about people stay with them because they love the DPC benefit, right? Those are 2 that can actually be quantified. Now, we haven't done it yet. We would need data that's specific to DPC, but those actually can be quantified, okay? I don't have it today, but I'm just saying that they could be. Okay, so this is where we left off. Here's our little scorecard. Remember, we had the $17 gap this was on an average employer, okay? So we add this on, and you can see that we've more or less covered the gap. So the increased utilization there, I can't see it on the back here, so I got to look here, is worth about $7. Member cost share is about $10. Those are estimates, pretty reasonable estimates though. And as you can see, we've now, without even including the health improvement bucket and the sort of this generalized product bucket that we talked about on the previous slide, we've now largely bridged the gap. Like, we largely now have a coherent story for when you pay, in this case, an $85 fee, this is what you get back, right? And most of this is data-driven, right, from our first study. That's where I took the numbers. So you largely now have a story for an employer that gets them to at least a break even. That's a pretty good story, when you know for a fact that you don't have everything in there, okay? So that was on an average employer. Let's see what it looks like on a lower cost employer. So you can see everything is smaller, right? Everything is lower. And now, once again, we have a gap there, right? We sort of have this value gap, right? We can't quite totally get to the $85 fee. And that should make sense, right? Because on healthier populations, I think I forgot to say that actually, this is a low cost employer. So this is someone who's, I don't know, maybe they're in construction and you have a lot of healthy people, right? So everything squeezes down. There's not as many savings opportunities to be had, okay? Now, I think you know where we're going from here, right? We saw low cost. Who wants to see high cost? So this is what high cost looks like. Now you have a gap, but it's completely the other way, right? Everything is stretched out. There's way more diverted claims. There's more avoided services. Everything has gone up. The value has gone up. The savings has gone up. So on a higher cost employer, you actually have a better chance of, producing meaningful savings here. And again, can't emphasize this enough. We don't even have everything in here, okay? But you can see that it's almost off the top of the graph there, and that should make sense, right? Because what you're doing is improving health, and you're healing people, and healthy people don't need to get healed. They need preventative, right? But sicker people, there's a lot more savings on. All right. Let's wrap this up. I think I have some time for questions. I will try to leave time for questions. Okay, so what did we do? We asked the question, what does value look like? We wanted to get really specific. We wanted to build a quantitative framework to understand the type, the timing, and the magnitude of the specific sources of not only savings, but also some of the quality aspects of DPC. And this can be used for an employer prospectus, if you want to call it that, your marketing, what have you, okay? Now, I showed you 2 different groups. Your mileage is going to vary, and what I mean by that is the 2 different groups that I showed you, you could see that the value proposition of DPC is a little bit different for each. All right, there were some gaps on the one. You may need more qualitative, verbiage and explanations and things in communications. And then for the higher cost, it's a little bit different. Mileage will also vary by geography potentially, because costs vary by geography. It can also vary by the type of practice that you have. Jonathan Bushman was telling me, I think he's got 4 different sort of offices, and he says they're all different. They're all under the same banner, but they're all different. So type of practice and how you run your practice, that could vary as well. I put a note in there too. I don't know how much traction like VBC is getting with these more sophisticated employers, like asking you to put your fees at risk. I don't know how prevalent that is or not. If it is, you want to be cognizant of these numbers. You don't want to make a savings guarantee or put your fees at risk on a group that has very low potential for savings. Does that make sense? You actually, in those kind of arrangements, you want the less healthy groups, ironically, right? Because you have a good model, you are looking to be able to apply your model in a situation that will generate savings. Okay, third takeaway, don't be undersold. You know, maybe that should have been the first slide, right? Don't be undersold. You know, you guys have a good product and it's very explainable. We just need to do it. We just need to put it together. We get this all the time in the consulting business, right? Do a good job, you know, provide a good product, and get paid for what you do. The key to getting paid here and to really getting more employers on DPC, I think, is giving them this understanding, giving them this prospectus that will get them comfortable with the investment that they're making. I would also say benefits consultants, if the employer is working with a benefits consultant, they may not understand this either. We do benefits consulting in Milliman, and I know of at least one consultant that we had to have a conversation with them because we said, you're not looking at this correctly. This is within our own firm, not to bang on my own firm, but it was this particular consultant. So don't assume that they know what they're doing. You know, let's get out in front of the communications and try to explain this ahead of time. Product quality and savings are not independent. I showed them independently. I think the quality is what actually drives the savings, right? And Garrison said something really interesting 2 days ago, Garrison Bliss. He said, you know, when you try to define DPC, he said, DPC, the way you define it is by a culture, right? Which I thought was pretty profound. He said it's the culture that drives everything, okay? Now I think what he's saying is not inconsistent with what I'm saying here. The way I would sort of weave that in is that the culture is a culture of quality. You just practice good medicine, right? Or the quality is in the culture, or however you want to relate those two. I don't think that what I have here is inconsistent, but I thought that was a really, one of many profound points that Garrison makes. So my advice from the cheap seats here on DPC is, if the quality drives the savings, then be thoughtful with changes that affect your quality of your product. Now, you guys will know maybe better than I would, but I would think that product quality could be affected, like panel size, right, is the first thing that comes to mind. But it could be who you hire, what disciplines you hire, things like that. But again, you would know better. But just in general, you know, I think that the connection between quality and savings is an important one. And last one, beware of the timing of the savings and the duration of access that you have to your population. I want to do this really quick. So this is a graph by age across the bottom. The orange line is how long someone at that age stays with their employer. And so as you can see, as you get older, you stay with your employer longer. And as you get older, your costs go up. So this is really good news for DPC, right? A model that is relationship driven, right? What it means is that the people that can most benefit from your practice, right, are the people that are actually going to stay there the longest. Okay, so you get to someone in age bracket 55, 64, they're going to stay with their employer 10 years. If that employer stays with you for 10 years, you have access to that patient for 10 years on average. Right? It's not perfect, but. So this is actually precisely what you want as a DPC, okay, is you want this type of a relationship because this gives you the most opportunity for long-term savings. Okay, that's it. Well, shoot, I only left 20 seconds for questions. I don't know what flexibility we have, but that's up to Phil. But we have one here.
Does it work? Oh,
there you go.
It works. Yeah. So I appreciate all this. One of the questions I have is, my understanding of employers is that they fully realize the cost benefits of DPC when they're self-funded or level funded. And then my understanding is that those companies are more to benefit from that when they are the low-cost group. They have the healthy employees. And so you're here saying that DPC is of more value for the high-cost group. Do you have any comments on that or any data to reconcile that?
So the data that I used is real data. We picked groups that fit a particular health status profile. We kept the age the same, and we just increased the number of conditions. Just picked people that had more conditions, and then we run the model on that. So it's that model isn't really, it's not really magic. It's just algebra. It's really, if we know of the savings percentages, we can apply those percentages, and it's not always linear. Healthcare is the one thing in the world that certainly isn't linear. But we did use actual data to do that. Now, whether or not health benefit consultants realize all these numbers, that's kind of my point before, was that they don't all realize this. And we have examples where they don't, this is their business and they don't understand DPC. So I don't know if that answers your question, does it? Does it get close? All right, hopefully. Any other? I think there's one back there.
Maybe we can, there's one more question. Go for it. You got a mic too.
Yeah.
As you probably know, DPCs have the ability to contract for very low-cost labs. They have time to dispense medications as well. Does any of that data take the savings on those items into account?
No. Great question. There's things like that we would like to include. And we do have the ability to reprice claims, so we can do that. If we had data points that said, hey, it's X percent of Medicare, we can reprice claims to that level. So that's a really good point, and we will definitely do that in this study. Our latest study, we plan to reprice everything anyway to kind of wash out the cost differences per se, or at least to isolate them and look at the utilization, and then we'll look at those price pieces after that. So.